Okay, students, here's your recorded lecture for uh, chapters 21, 22, 24, and 25. So these are going to be quick lectures because you know how I love to record and I know how you love to listen. So, culture and ethnicity, here are your learning outcomes for the chapter. So, I've said this before, when we're doing our admission assessment, we need to make sure that we ask the patient about any ethnic, cultural, spiritual, religious type of practices that may affect the care we give them. And there is a huge dietary practices, that could be a problem. So we need just to make sure we assess for this, and if there is something that they bring up to us, we need to make sure that it gets passed on every time we change nurses. Okay, and it may be something that we also need to pass on to the dietary department or the chaplain or other healthcare providers, things like that. So it's an important aspect in the care we provide. Now, there's some concepts that you do need to be able to tell the difference in because I think you might see this again, especially when it comes to generalization and stereotypes. So generalization is a statement, an idea, a categorization that is applied broadly. Okay, so for instance, if you have a patient who professes to be a Jehovah's Witness, and we know that many Jehovah's Witnesses will refuse blood products. But when your patient comes in and you say, do you have any spiritual or religious affiliations or anything like that? And they say, well, we're Jehovah's Witness. Don't automatically assume that they are going to be against receiving blood products. That would be a generalization, okay? We're drawing a conclusion based on what we most experience from people who are Jehovah's Witnesses. But this person may not want to refuse blood. So we need to make sure that we ask specific questions and do not generalize or assume, basically, things about the patient. Now, a stereotype is very similar. It's ideas that we have often unfavorable of a group of people. So we could say that all Muslims or all, we should say all Muslims, are terrorists. I'm sorry, this is the best example. So that's a stereotype. That has a negative connotation. It's unfavorable, and it's not true. Okay, and you can even say that African American men who wear hoodies at night are dangerous. Well, that's a stereotype. That's an unfavorable impression or characterization of black men who wear hoodies at night, when that totally may not be true of everybody that is a black male who wears hoodies. So we cannot make these unfavorable or these stereotypical decisions about our patients. Now, when you see stereotyping in practice or in your unit or something like that, you may want to educate or suggest education or present education to your coworkers or whatever about stereotyping different cultural groups or things like that. Hold on. So we just need to, so there's a couple of questions on your exam related to generalization and stereotypes. So just be sure to focus on this and some examples and how to best confront either in yourself or with your coworkers these kind of things. Okay. There's actually several questions, scenarios, and asking you how to respond to those kind of comments or things from your coworkers. All right. Transcultural nursing. So this is actually a specialty in nursing. You don't see this much maybe in our area, but maybe in some areas where they have lots of different cultures that make up the population of that community, you might see that transcultural nursing actually has a legitimate, or not legitimate, but that there are actual positions for transcultural nurses. Okay, and so we can consult with these nurses as far as providing the best care to this population. You might see this a lot in the outpatient or community setting, public health setting that serves a community or a city or a town that has a very diverse population of culture. And so when you're trying to do community health education, you have to take people's culture into consideration when you're providing this education, because there are probably some things in which this culture practices or will not practice. And so in order to provide the healthiest alternatives for them, then you might need to rely on a nurse within that specialty, or a transcultural nurse to provide that special type of education. Okay, so some terminology that you might want to know about as far as cultural competence is cultural sensitivity, culturally congruent care, cultural competence. So cultural sensitivity just is being aware or recognizing that there are differences among cultures, and so it's not a black and white it's not black and white in how we provide our care. There's some diets that we recommend that some cultures will not follow, because some of those items in that diet are not practiced in their culture or something like that. So we have to be sensitive that that there are differences, and that we have to try to find the best way around that. Providing culturally congruent care, of course, is having a knowledge base, having knowledge, and of course the cultural sensitivity, and being creative and finding safe alternatives for this group of people. Okay, cultural competence is just a general term, and someone who is knowledgeable, has the correct attitudes, and the correct skills in order to provide care for these people. Is that nurse is considered to be culturally competent. So now, so even if you feel that you are culturally sensitive, that does not mean that you are culturally competent. Being aware that there's differences is great. It's like the first step in acknowledging that there are differences. But to be culturally competent, you have to have a little more than just a recognition of differences. You have to have the knowledge of those differences and the knowledge to be able to put out a plan of care that these different cultures can accept. So that's kind of my best explanation to one of the questions on your exam. Okay. Okay. So when it comes to cultural competence, there is a lot of things about that culture that we have to be aware of. And of course, communication is one of them. Language. So we need to be careful when we speak. Even if they do understand English and can speak English, we have to be careful about using slang terms, nonverbal language. We have to be very perceptive in how we're actually speaking to these people. We don't have to, I mean, if you've ever seen someone talk to someone whose English is not their first language, have you ever noticed that they talk louder, like the person's deaf? Like, we don't need to talk louder. We just need to make sure that we do not use slang terms, because they don't understand slang terms. It's very difficult for them. So if they do not have, or if they do not speak English, or if they do speak English but have, speaking English and understanding what medical terms are, there can be a huge difference. So they may be able to speak fluent English on a normal day-to-day basis, but understanding healthcare lingo, they may not be able to. So for those people and those people who do not speak English, we must have a qualified healthcare approved interpreter, especially when we're asking questions about their health history, especially when we're giving education about their disease or their illness. Okay, because we need to there's some things that you can use the family for, like really benign things, like, are you having any pain? Well, the family can say, are you having any pain? Do you need to go to the restroom? If I walk in and say, okay, it's time for you to get up and walk. Like, we can use the family to help us. We don't need to use an interpreter every time. But when we're giving healthcare information and we're asking about health history and those kind of things, we need to make sure we have a qualified healthcare interpreter. Space is a big thing with some cultures where their personal space is very large. And then also, when it comes to space, you can also sometimes include physical touch in this category. Some cultures, there's a problem with physical touch, so we need to make sure that we are aware of those kind of things. Time is actually a big thing. So a lot of cultures don't consider future and healthcare practices today and how they'll affect you in the future. They don't put that together. That's not a thing for them. So they don't understand why they have to do that. So sometimes that's a big thing. Environmental control, cultural health, okay, and then and of course, different cultures, there's a lot of biological variations, of course, but some of those may also affect disease processes. So there are some diseases that are more prevalent in different types of ethnicities, so we need to be aware of those things as well. Let's see. Now, when it comes especially to cultural beliefs, and I don't really call this a religious belief, this is their culture where they have their elder or their spiritual guru person that, because some cultures, it has to do with the way you live, your life choices, your things like that, why you have disease and illness. And so it may not be something, the treatment, medication, procedure may not be something that is allowed in their culture, or they may not know if it's allowed in their culture. Some of these things are new. They're not things that this culture usually deals with. So so sometimes the elders of that culture or their spiritual group need to actually make this decision for the patient. Now, so some people may have a problem with that, but if this patient wants to follow their cultural practices and they call one of their cultural bosses or whatever to see whether or not this procedure or treatment is okay based on their culture. And if that person says, no, we don't agree with that, and then that patient says, well, no, they said no, then that is their decision. That is us supporting their desire to fulfill their cultural practices, even though we feel like that other person made that decision for them. Yeah, they did, sort of, but that's the patient's choice, is to defer to their cultural leaders' wisdom, advice, and such and so forth. So we need to allow that to occur. So definitely, you know, when we're doing our care plans and things for people with different cultural practices, we need to make sure the care plan that we feel that we've come up with is congruent with their cultural practices and things like that. Okay, a lot of things that you're going to see is the concept of equalization of genders. So that means, one, like same-sex caregivers. Like, actually, I just got home today from my OB clinicals, and we had an Arabic couple come in. She spoke absolutely no English. He spoke English. We did get an interpreter for the important things like that I had mentioned before, but one of their things was no male providers. And so we actually were able to accommodate that. But what if you get into a situation where you can't accommodate that? So you do the best you can to accommodate that, but you can't snap your fingers and pull a male nurse or a male physician out of the air. So you might go in and say to them, look, we've done everything we can. There is not, we've called everybody, we've looked, there is not same-sex caregiver that we can do. This is all we have. Okay, and so they either are like, no, we're leaving, or they're like, okay, well, I must be usually this is a female thing. There are some male things, but usually this is a female thing. They only want a female in there. So if that's the case, then the male would be like, well, then I have to be here every time and approve of everything he's going to do. Same with the male. Like, if the male patient wants a male caregiver and we don't have a male caregiver, then they may have a male spiritual leader or someone from their culture being present, okay? And we might have to jump through hoops for the female nurse. But anyways, I've already talked about time orientation a little bit. Body odor. So we think people who have body odor have poor hygiene, but in some cultures that's acceptable, and that's a preference for them, is to have a natural body odor. Okay, some cultures find it offensive, some feel that that's important. And we've already talked about food, so there could be huge food things that we need to deal with. All right, so when we're here's our health assessment questions. Like, here's some specific things we can ask about their culture. So if you are not knowledgeable in this culture, you can ask specific questions, or you can say, with most Arabic patients I have, they ask for this, that, and the other. Do you want those things? And they probably will say yes, but maybe some of them will say no. Okay, there is a lot of American-bred people of culture here. American-born, and some of them don't embrace all the practices of their culture. Some of them do. So we just need to, not make that generalization, and then just ask the questions. So not using abbreviations in our speech. Talking slower, not necessarily louder, Do not use humor or slang, puns or sarcasms, things like that. We can't use those with people who don't have English as their primary language. Now, when we provide written materials, hopefully we can get those in the patient's language. There's no use in providing English education if the patient doesn't know how to read it or cannot understand it. So maybe there's some audio visual things, so we'll have to do some hopefully investigations. This is what would be one of the great things for a transcultural nurse. She probably knows of resources where we could provide education for our patients according to their culture and their language. Oh, great. That one's done already. So let me just review here a little bit. Okay, so let's move on. Let's go to spiritual. Okay, so let's do spiritual health. Okay, so here are your learning outcomes. Okay, so when I'm talking about when we're going over this chapter, this seems like, oh my gosh, really, like we're doing this huge religious assessment on people, and not so much. So in general, especially when you're doing your admission on your patient and you ask that question, are there any spiritual or religious practices or beliefs that that you do daily that I need to be aware of to help you accomplish these things while you're in the hospital? And if they say no, then we're done, basically, pretty much. Sort of. In general, in the most part, we are. But if they do say yes, there are some things, then we need to do some further investigation. Okay. So we've already talked about kind of Jehovah's Witness. Cultures have specific healthcare related practices that they do or do not do. So we need to find out about those. Spiritual care, and actually, let me see what this says. Okay, so this is ways that we can help provide spiritual care. This does not mean that we agree with their spiritual practices. This does not mean that we need to participate in any type of spiritual practices. But when we provide spiritual care, we're at least acknowledging that there's something, and we're helping to provide a way for the patient to realize those things or participate in those things while they're in our care. Now, if it is a spiritual practice in which we do practice ourselves, we are more than welcome to participate in those things, as long as any spiritual practice or cultural practices, for that matter, do not break hospital policy. Okay? All right. Now, definitely one of the avenues that we can pursue is, most hospitals have a hospital chaplain, and if they're not, and some hospitals, that hospital chaplain doesn't have office hours or do patient rounding. Some hospitals they do, especially Catholic hospitals like St. Pat's. But some at least have a list of what they call on-call spiritual chaplains or pastors or preachers. So it's people who have agreed to be available to patients that day. This pastor is available to the patients today. I need to call this pastor or this preacher. Or the patient may say, I want you to call mine. And so we would definitely, if they gave us permission, we would definitely call theirs. There are lots of times during patient experiences where it would be good to ask outside of the admission assessment. So you've been taking care of this family. This patient went and had surgery. They were expected to come out of the surgery just fine. Something bad happened. They had a negative outcome. And now this patient's life, we don't know if this patient is going to live. At that point, we might want to, when we talk to the family about what's going on, we might want to even at that point say, is there someone we can call. Would you like the chaplain to come visit? Things like that. So we can, and certain kinds of things like when a patient comes in and they're going to die, or they've been given a terminal diagnosis, or the birth of a new baby, or the birth of a baby that has died or is going to die, situations like that. We may bring up the subject, okay? And then, research has shown that patients want their nurses to connect with them and understand them on some spiritual level. They do expect that out of their nurses, even if that spiritual connectiveness is just offering hope, showing that you care, helping them understand and find meaning in their diagnosis. You don't necessarily need to support and say that you believe in God, but if you do, by all means, say that. But just providing an environment in which the patients can feel spiritually cared for in some way, shape, or form. Okay? So I encourage you all to do that. There is a specialty in nursing for that, by the way. You can be a parish nurse. Most of these type of nurses do work in the community setting. However, in Catholic organizations, Catholic hospitals, you may see parish nurses. Okay, and they may work in the chaplain's office doing with chaplain services, or parish nurses may actually be your staff nurses as well. So here's some assessment questions. I'm just looking, I just want to look at something here. We talked about different things that happen with your patient that you may bring up the subject about a chaplain or a spiritual advisor or pastor or something like that. And again, like I said, you do not need to participate in any spiritual activities unless you feel comfortable in doing so. But you do need to provide those opportunities for the patient. And by all means, there should never, ever be a debate on religion with a patient and a nurse. Okay? If the patient asks you what you believe, I think that crosses a line that we should not, especially when this patient is seeking some sort of spiritual understanding. I feel like if a patient asks you a question about your spiritual beliefs, I feel that that is crossing a line for the nurse in providing that information. So, and having said that, I am not afraid of ever telling a patient if they've asked me where I stand spiritually, but I just feel like you need to make sure you're very professional, and if you do decide to share your personal beliefs, I feel you need to be very careful in the way you share that, and don't be condescending to any of the others that are different from yours. So I just kind of contradicted myself, but I'm just putting it out there. Like I say, this is what I feel. Like I should encourage you, like, to maybe not cross that line, even though I've done that myself. That's my choice, but I feel like it's just a safer thing, and I think I should recommend to you that you don't cross that line. But if you feel comfortable in doing so, I just encourage you to make sure that you do it very professionally and very respectfully of other spiritual beliefs. Okay? Okay, so let's stop beating that to death. Okay. All right, so here's our health assessment questions. And then I told you about different patient scenarios in which you might bring up the topic of some spiritual support for your patient, but also look for cues that may indicate that the patient needs some spiritual support. And that can be verbal things the patient says. It could be nonverbal behaviors. It could be things that you're seeing in the patient's room, things like that. So here's some examples. If a patient seems angry, depressed, tearful, you might want to say do you feel like you would like some spiritual support? Would you like the chaplain to come? And they may not, okay? And then you can address these things yourself. If you see spiritual items in the room, and you know that there's no chaplain or anything like that coming, you can, ask or offer. And then just by things that the patient says, like here, like God willing, or if they say blessings, or if they say please Jesus, or something like that, that gives you an idea that they do have a strong spiritual aspect to their life, and you may want to ask and see if chaplain referral or calling someone from their church or something like that would be appropriate. Here is just some more examples of some cues that we might want to pick up on. Let me look here for a minute. Just like I had mentioned with cultural leaders saying yay or nay to the patients, for the patient to make their decision on certain practices, it's the same thing with religion. So there are some religions, like the Muslim religion, that has some pretty specific dietary practices, and according to their diagnosis and their care plan, we may be asking them to do something that is contradictory to certain religious dietary practices of the year or the month or whatever. And so they may need to consult their spiritual leaders to determine what to do in that aspect. So we should make sure we provide that opportunity. Okay, so I think I've covered a lot of this. And culturally and spiritually, if a patient expresses certain practices that they do or don't do, and we disagree with them, especially on a medical basis, we should not be presenting our side like, that's really stupid to do, and it's going to cause you a lot of harm, so you really shouldn't do that. You can just present, well, the studies do show that this is very important when it comes to treating your illness. We see in the studies how this illness can be managed very well or whatever. So we need to present it in a very non-hostile or defensive or condescending way, and hope that the patient is like, well, I get it. I would like to talk to my people about that and see if that's something that I can do in this temporary period or whatever. So we just got to be very careful. Here are some nursing diagnoses when it comes to spiritual stuff. Here are some patient outcomes. Let me just look at my thing here. There's one question on here that I see that I wished I would have remembered to get out of here from last semester. Let me just read it really quick and see if I can help you with this question, because it's caused a lot of controversy. All right, so yes, this one is a really hard question. So I don't know so I'm just going to tell you the answer. Okay, I'm going to read the question to you and tell you the answer. So if you get it wrong, I'm going to slap your wrist. Okay, no, I'm not. But anyways, so it says a home healthcare nurse has been working with a patient who has the nursing diagnosis, spiritual distress. After a few weeks of implementing the care plan, what method is best for the nurse to determine if the goals have been met? And the correct answer is ask the patient to what extent he or she feels the goals have been met. That is the correct answer. Okay? All right. You're welcome. All right. So I'm just moving on here. So here's just some interventions. Just allowing the patient a time and opportunity to speak, to express themselves, being physically present and listening to your patient. I've talked to that. I've talked about that a lot. That's not just a spiritual thing. That's I care about you and I'm interested in what you have to say type thing. So that's good for nurses. Support whatever they need to do as best you can. Arrange, make sure that their religious advisors or chaplains can be present, or any type of support, their support network. Here's some comments that you can practice with your patient when you recognize some cues from your patient. Like the first one says, for example, the nurse may initiate reflective interventions by stating, this must be a difficult time for you. Much has changed. What are you thinking? What are your thoughts? Let them express themselves, just like the previous slide had said. You may ask, is there someone with whom you would like to talk? Can I call family or friends? Can I call your chaplain, your pastor from your church? Can I call our chaplain? So just come right out and ask. And then, we should allow them to do whatever they need to do, except if it breaks hospital policy or puts other patients or staff in danger. One great example is lighting candles or burning incense or things like that. We can't do that in the hospital. Okay. And again, avoid sharing personal beliefs. So that's just a general rule. So you make your decisions, and then just try to be respectful and not condescending. All right, so this is coming from the aspect of the nurse. So this is always just saying, like, we're constantly taking care of patients and providing for them, but are we having any spiritual distress ourselves? We need to make sure that we're dealing with our spiritual things ourselves, and in order to keep us healthy spiritually, therefore keeping us healthy overall, and not being burnt out or things like that. So we need to make sure we're taking care of ourselves as well. Oh, I thought that was the end. Oh, this is still about the nurse. So this is just ways for the nurse to, some suggestions for the nurse to help with her own releasing her spiritual distress, or helping her engage in her spiritual practices. And here's, you don't need to be a Catholic or a Buddhist or anything to have some sort of spiritual reflection and some spiritual release and some spiritual support. Okay, there's all kinds of other things you can do. All right. And then evaluation, making sure that our care plans meet our patients' goals, and adjusting them as needed. Okay, so now we're going to move on to, I think it's sexual health. This is actually a super huge PowerPoint, only because I added extra stuff for you, not necessarily for the exam. And when I come to that section, I will definitely point them out to you. So human sexuality, here are your learning outcomes for the chapter. So sexual development. Depending on what area we work in, we're not going to always be, our 90-year-old med-surg patient that's there with pneumonia. We're probably not going to be doing a huge sexual health assessment on her. But in some areas, like in OB or in public health or in clinics, this may be a big issue. Excuse me. So sexual health involves the development across the lifespan. And so depending on, like the pediatric population, there might be some things as far as normal sexual development that we need to be aware of. And then, of course, in a reproductive age, there will be things to deal with in the adult life, and an older adult, there's sexual health things that we may need to deal with. So it starts from, actually sexual development starts before birth, but that's being too technical for this lecture. But anyways, there may be gender identity practices that we need to be aware of and respectful of and help our patients with, especially if they're having an identity crisis. Sexual response issues that we might need to deal with, contraception issues that we need to deal with, sexually transmitted diseases, and then factors, health, especially health, factors that may affect our sexuality and our sexual function, which are two different things, and the textbook does explain those to you. These next slides are just for your information and knowledge. You should be aware of the different sexual health characteristics that occur throughout the lifespan. So I do want you to kind of read over this and kind of be aware of things that happen during these different age groups. Okay, so and I will point specific things out if I need to, but right now this is, I don't want you to skip over looking at this, please. All right, so some common problems that we are going to be facing is infertility issues. Infertility is after 12 months of conception-free intercourse, where they have been actively trying to conceive. After 12 months, they have not conceived, and 12 months is the criteria for those females under 34 years of age. If they're over 35 years of age or over 34 years of age, then we only give them 6 months, but it has to be contraceptive free and active attempts. It can't be just a once in a while thing. It has to be a monthly active attempts to conceive. Perimenopause is the period prior to menopause, and through the first year after menopause. So that's perimenopause. And then menopause is the period of time when she has not had a menstrual cycle for 12 months. Okay. We need to be aware that sexual activity does occur in the older adults. In the 65 plus year range, sexual activity still does occur. And depending on what their illness is or what medications or, what their disabilities are, that may be a problem that they want to deal with. So we need to be able to have these conversations with our patients. And then the male himself may have some erection problems that he needs to deal with. Just age alone, but also if there's any medications, specific medications, or if he has any disease process that puts him at risk, then there's problems that we need to deal with. Now, men are usually very reluctant to discuss this, especially with female providers. But if you are that female nurse that is talking to this guy about something that you know causes problems with sexual function, then you need to be able to bring that subject up with him. And if he's not comfortable talking with you, but he does want to talk about this issue, then you need to find him someone that he can talk to. Okay? Contraceptive options. I think this is one of those areas where I gave you more information than your textbook. So I think I've talked to you, I'm sorry. So contraceptive options. Of course, this is for birth control. There's many different methods, barrier methods, rhythm methods, calendar methods, hormone methods, device methods. There's all different kinds. And then not one contraceptive option is good for every person. We need to do, an interview of the person, a history, just trying to get a feel for what their sexual practices are, what they want to see from their contraception, and then be able to recommend what's best for them. Because if it's not a plan that's best for them, that they will do consistently and correctly every time they need it, then it's not a good plan for them, and they end up getting pregnant. So table 24-2 on page 446 gives you a list of all the different contraceptive options that we may recommend for our patients. Now, the medication-free, there's several different names. The natural family planning and the fertility awareness are very similar. So the natural family planning is avoiding intercourse during the fertile times. It's effective 75% of the time. And then so if a patient chooses this, then we need to make sure we educate them on when is your fertile time. When can you expect for your fertile time? How do you figure out when your fertile time is? What are some signs and symptoms that you will notice that will clue you in that this may be your fertile time? This is why it's only 75% effective, is because there's mistakes in identifying that fertile time. And that fertile time is actually a range of a few days. So they may hit the few days a day early or a day late or something like that. And then fertility awareness based is very similar. This is really silly to me that there's two different definitions. But basically that during their fertile time, they use abstinence, which is the above, or contraceptive, using some sort of contraception during their fertile times. Okay. And again, 75% effective, and it all goes back to knowing how to determine when your fertile time is. Coitus interruptus, that's withdrawal before ejaculation, 71% effective. Just a little note, my sister did this with her husband for 10 years during their marriage and did not get pregnant. So it was, and then when they decided to have kids, they stopped doing this, and of course she got pregnant. But anyways, but yeah, like I told her the whole time, that's really bad choice, sister, that's really bad choice, but she did it anyway. Okay, lactational amenorrhea, this is 98% effective if she is exclusively breastfeeding. So, and this is when baby's 0 to 6 months. After 0 to 6 months, the effectiveness drops, and it's related to baby starting to be introduced to other foods. So it's not exclusive breastfeeding. Okay. And then of course, abstinence is 100% effective. Abstinence is you not having sex at all. There's the barrier methods. These are really great because they're inexpensive. Barrier methods protect against STIs. You use them right right before intercourse, which can be, a downer for spontaneity and things like that. You need to use water-based lubricant kind. There's really no side effects unless it's a latex product and you're allergic to latex. The big thing is using them consistently and using them correctly. Barrier methods, there's the diaphragm and the cervical cap. These are things that are placed over the cervix before 6 hours. You leave them in place after intercourse for 6 hours for the diaphragm. And then the cervical cap is very similar. You put this in and before sex, and then take it out while after sex. I would wait at least 6 hours myself, but it can be worn up to 48. Now, using barrier devices, by the way, and leaving them in longer than they should be in, put you at risk for toxic shock syndrome. And then these things, the patient needs to be educated on correctly how to place them and how to take them out. The timing and all that kind of stuff, they need to be educated about. But the one thing about these is spontaneity. So the fact that you can put these in well beforehand is great, but there's always those instances where you're not expecting to need one and you need one, I guess. Okay. Condoms are another type of barrier method. There are male and female condoms, male condoms being the most frequently used. We have spermicides, so they come in the form of gels, creams, or suppositories or things like that that kill the sperm. We have the contraceptive sponge, kind of similar to the diaphragm and the cervical cap. And so those are different barrier methods. Our hormone methods are either an estrogen progesterone or a progesterone only type of birth control. The thing about these things work because we keep the estrogen and progesterone levels at a steady high state, which causes a negative feedback to the hypothalamus to not release gonadotropin releasing hormone, which then stimulates the pituitary gland to release the follicle stimulating and the luteinizing hormone. These hormones are what helps grow the follicle in the ovary and cause the follicle to spit out the egg, which is ovulation. So if we keep the estrogen and progesterone levels high, then that doesn't occur. Okay, so those hormone methods could be in the form of oral contraceptives or the pill, the birth control pill. There's a couple of different types. So the estrogen and progesterone that are with each pill can be different according to what phase in the cycle that you're in. So the physician will determine what would be best for the patient for those. Great benefits for hormone methods are listed here, so you can look through those. Contraindications, hypertension, a big one, clotting disorders, super huge contraindication, and then smokers. It's listed here as a contraindication. However, they will give birth control, hormonal birth control to people who smoke. They're just going to tell them you're at increased risk for blood clots and strokes and things like that. The side effects for birth control are scanty periods, or depending on if you don't, especially if you don't have a great option for your body, you might have breakthrough bleeding. Some women experience nausea, definitely breast tenderness, headaches, and weight gain. But the side effects, which are really important to teach your patient about, that they need to actually call their doctor or healthcare provider or whoever they see. You can remember by the mnemonic ACHES. So ACHES standing for A for abdominal pain. So not just your normal cramping, but severe abdominal pain, and it could be blood clot in the liver. So we need to check on that. Chest pain, anybody who complaining of chest pain should see the provider. Headaches that are abnormal and intense, especially if they're causing blurred vision or problems with vision. If you're having weakness or difficulty speaking along with those headaches, or even if you're not having those headaches, you're having those symptoms, you need to report. Eye problems, so if you're having any type of visual problems, we need to report. And then severe leg pain, so symptoms of a clot, she needs to report. The other hormone method pill that I want to point out to you is a low-dose progestin-only pill. It's called the mini pill. We recommend these for women who are breastfeeding, but especially for women who cannot have a contraindication for taking estrogen, and so your smokers and your people with blood clot histories, we might suggest this type of birth control. Other hormonal methods that are not in the form of a pill are the transdermal contraceptive patch. So you wear the patch for 3 weeks, you take it off for your week, and then you put a new patch on for 3 weeks. Okay. The vaginal contraceptive ring, that's very similar to the patch. It is placed, left in for 3 weeks, and then removed for a week, and then a new one's put in after the 4th week. Okay. Depo-Provera is an IM injection one. It lasts for 3 months, and then you come back and you get your next injection. And then the implanons, the implants, subdermal implants, the little sticky looking things that go under the sub-Q of the skin, Implanon or Nexplanon, so they last 3 to 5 years depending on the brand. They're put in the office, they're taken out in the office, and then but they last for 3 years. These are progesterone only. So if her conception plans change in the 3 years, she can take these out, have these removed early. Okay. But as long as she has them in, they're good for 3 years. Okay. Then there's the IUDs. Depending on which one you use, 3 to 5 years for the Mirena or the Skyla. And the Copper T is for 10 years. These are placed in the uterus. These can be placed in inpatient, so you just leave them in there and for the entire period, and then take them out and replace them if it's time. These also can be removed early if you decide you want to become pregnant. All right. Shoot, I'm sorry. Side effects. So the warning, the bad ones that you need to teach your patient to report, you can use the mnemonic pain. P being period late. Well, with a lot of these IUDs, you don't have a period. So if you have the IUD and you do have a regular period, even if it's only 3 or 4 days instead of the 6 to 7 days, then that is the norm. The way your body responds to the device, that's the norm that you can count on seeing. But if you're having those periods and then all of a sudden you're not, then that could be a problem. Again, abdominal pain, infection, not feeling well, so fever, chills, and the string missing. So when you put these IUDs, there is a string on the end that hangs out the cervix, and you can actually feel this you can actually feel this hanging out of the cervix. So it's a good thing to teach your patient to check on that occasionally, like once a month, to check to make sure that string is still there. If it's not there, then that's a problem. She needs to go see her doc. All right, so emergency contraception. So there's where she can take and some of these are over the counter. The IUD, of course, is not over the counter, but the pills are over the counter that she can take, or she can go in to her healthcare provider and have an IUD. So, yeah, these, I don't have anything else to say about these. Okay. Sterilization. So this is where we have the tubal ligation. For the female, she has the tubes tied and cut. That's supposed to prevent pregnancy. The non-incisional hysteroscopic tubal occlusion. So this is an Essure. I think the brand name of the product is Essure. This is like a it looks like a little spiral wire that they put like right into the opening of the fallopian tubes, and what happens is the fallopian tube scars up and it adheses to these to this device, and anyway, so they're pretty effective, both the bilateral tubal and the Essure tubal occlusion device. They're not 100% effective because even the tubal ligation. So it can accidentally, the tubal ligation can accidentally reastomose, or kind of like form together again, and a pregnancy occur. The occlusion device may malfunction and allow a pregnancy. In the male, of course, he can have a vasectomy, where his vas deferens are cut. These are 99% effective, and again, the reason why this wouldn't be fully effective is because it reastomoses some way. So if you got a patient coming in screaming that his wife cheated on him because he had a vasectomy, just don't, and she's screaming she did not, just don't assume that she did. Like, we might need to do some testing to determine if he can produce some sperm. So anyways, so we've talked about these two procedures already. Okay. The other that's not listed here is a hysterectomy. Of course, that is permanent sterilization, but not really part of this topic. So all right, sexually transmitted disease. Patients may be embarrassed that they're coming in and saying, I think I need to be tested for a disease. We need to make sure we're non-judgmental. We make sure that we are not showing any nonverbal cues that we're appalled at our people or whatever, or that we're judging or anything like that. Like, we need to treat this as normal as someone comes in and says, I think I have high blood pressure. You need to allow your patient to trust you and to be able to tell you everything they need to tell you, and so that you can, one, treat them and also educate them if they need it. Okay. So this is where I get that I've added 1,000,000 tons more also of slides. So if you look at page 448, so these sexually transmitted disease on 448, including HIV, which is also presented in your book, are what you are responsible for. I provided everything else because I care about you all and I want you to have that information. Okay, so it's overkill. So let's just talk about the ones that are covered in the text. So HIV and AIDS. So we know HIV is the virus, human immunodeficiency virus, that causes AIDS. It affects the macrophages and CD4 T cells. It's spread through the lymphatic system. And then at some point it does progress to to AIDS, acquired immunodeficiency syndrome, and that's what patients die from. It's transmitted, of course, sexually, and then through IV sharing or exposure to blood and body fluids. So healthcare workers can be exposed. So symptoms are, they can be asymptomatic, or they can be complaining of vague flu-like symptoms. Risk factors, of course, history of drug use, history of prostitution, frequent intercourse with multiple partners, of course, sexual intercourse under the influence of drugs and alcohol. It just says drugs here, but oh my gosh, really? Drugs and alcohol. All right, and that's basically your risk factors for any sexually transmitted disease. Okay. So screening recommendations. This is, I don't know if your book talks. I don't think your book talks about this. So of course people can come in and say, I think I might have HIV, and of course they want tested. But there are some clinics, that have requirements for HIV testing. So for the perinatal patient or the pregnant patient, the Centers for Disease Control have either an opt-out, opt-in testing solution for the clinics. So an opt-out testing is all patients are tested, and we're assuming, or we're saying that consent is given if the patient does not specifically decline the test. So everybody's getting tested, and the patient has to say, no, I don't want it. Okay, and if they say no, they don't want it, of course, we're not going to do it. Opt-in testing is, yes, we do offer the patient the test, and they must give us permission to do it. Okay. ACOG recommends that women 19 to 64 are screened for it, or at-risk populations, and at-risk populations. So 19 to 64 really covers a lot of women, but you have that before 19 years of age that might be people at risk. So the U.S. Preventative Task Force, they recommend 15 to 65, and you may have an at-risk person who is younger than 15 that you may need to test. Okay, so here's the different screenings we're doing. Remember, a screening is a screening. So if you have a positive test, you need to do something more diagnostic. So you probably heard of the ELISA test. So we can do that test. They have newer testing than when these slides came out, the same day testing that can be done. So anyways, of course, there's no cure. But there are treatments to decrease the viral load, and try to keep the patient as healthy as possible for as long as possible. And then we can also give an antiretroviral to pregnant women throughout their pregnancy to try to prevent transmission to the fetus. Okay. Of course, there's of course a lot of psychosocial issues that are related to women with HIV, and not just women, but I'm sorry, these slides are OB specific slides, but even your male population. So there's a lot of things we got to do for our patient besides just say, hey, you have HIV and here's your antiretrovirals. Like, we need to provide social psychological support, bring in their family or supportive people if we need to. And then as far as there may be other concerns because this patient has HIV, they may have other issues that we need to deal with as well. So we need to check on those things. So I think chlamydia, gonorrhea, herpes, and HPV are the sexually transmitted diseases that your book talks about. I haven't been referring to my special notes. Just hang on here. I just kind of want to see Remember when I said before about the hormones? The contraception, oral hormonal contraception. You just need to remember that the reason why we're using estrogen and progesterone is because when we get that high, steady serum level, it provides this feedback loop to the hypothalamus to not release the gonadotropin releasing hormone, which then stimulates the pituitary to release the follicle stimulating hormone and luteinizing hormone, so to prevent ovulation. So just know about your non-prescription options, your barrier methods. Let's see, I'm sorry. Now, when it comes to sexually transmitted diseases, we need to be careful, especially when a patient comes in. We need to do a lot of history and asking uncomfortable questions like, how many partners do you have? We need to kind of like recommend that we alert all those partners because we don't know who's the culprit and who's getting given what. So, that's a hard thing for a person to do, but especially if she's got what she considers a monogamous partner, and one of the people are like, you infected me, you cheated on me. So we need to know that a lot of these sexually transmitted diseases are asymptomatic. So someone may have been carrying this thing for a lot longer time than they had been with this person. So we need to make sure we keep everybody like level-headed and not jump to conclusions about who's doing what. Okay? All right. So fortunately for you, I do want you to be aware of these sexually transmitted diseases. Like if chlamydia can be asymptomatic, but you may have some abnormal discharge, maybe some spotting, bleeding type things. Those may be your symptoms. A lot of times chlamydia is found on her yearly Pap test, and she didn't know she had it. But know that chlamydia can be treated. I don't expect you to know what the specific treatments are, at least for this course. But gonorrhea, you probably just want to know what kind of symptoms there are for gonorrhea and that it can be treated. So the important thing I'm trying to say is chlamydia, gonorrhea, and syphilis can be treated. Herpes, HPV, and HIV cannot be cured. They can be treated, but they can't be cured like the others, okay? Trichomonas is not in your text. Pelvic inflammatory disease is not in your test, but HPV is in your test. I mean, not in your test. It's not in your test. It's in your text. So I want you to be aware about HPV that we recommend. There's all kinds of different strains. And there's no treatment for it, but there is vaccination for HPV. The Gardasil 9 is the one that has treats the ones that are most specific to the ones that cause cervical cancer issues. Okay, the treatment for the actual warts, can be laser surgery or chemical treatments, electric heat treatments, or whatever. But specifically these, and then herpes. So herpes can't be cured, but it can be treated. And the treatment is just to prevent the outbreaks that they may have. And we'll talk about herpes more in OB next semester. Okay, and we talked about syphilis. Okay, so there is actually so there's a lot of stuff I put in here that's not in your text. Just for your benefit. That's all. Okay. There is no specific questions on the specific STIs on the quiz. Okay. But there may be some general questions about sexually transmitted diseases, but no specifics. Okay. All right. Okay. Let me just see where I'm at. I'm just kind of curious. Hold on. Oh, no. I didn't get that. Okay. I was just looking at our time. All right. Okay. So, just know the difference, sexuality and sexual function. So sexual function is the process of conceiving and procreating, okay? Sexual function involving sexual development, hormones, and the act of sex, that is sexual function, or the ability to have sex. That's sexual function. Sexuality is the character of the person related to it is related to sex, but it's their character. It's more about their character, their disposition, related to intimacy and things like that. Okay, and sex doesn't really even need to be a part of it. Okay, the actual act of sex. Okay, anyways. Here's factors affecting sexuality, and factors affecting sexual function. So definitely we're going to be seeing some illnesses, diseases, processes, and even our treatments affect sexual function. So we need to be aware of those and then counsel our patients if that's going to be something important for them to work through. Here's some medications that commonly are associated with sexual dysfunction. So if your patient is if you're passing out prescriptions for these patients and educating them on these medications, we'll need to talk to them about sexual function if that's an issue. Here's some more medications as well that affect sexual function. So here are your health assessment questions, and these are this is if whatever's going on with your patient, their health and their treatment does affect their sexuality and sexual function. And this is also if your patient is coming in for and asking for this to be addressed. Okay, so here, these are not typically questions we're going to ask of every single patient that comes in the hospital. Okay, so this is just for those select patients. Okay. And again, the way we talk to our patients about all this stuff, sexual function, sexuality, sexually transmitted diseases, we need to talk to them the same way we talk to them about the medications they take, what surgeries they've had. The way we present this to our patients is going to really have a lot of effect on the way they open up to us, and tell us all the information we need to trust us to tell us the whole truth and nothing but the truth. So help them. Okay. So these are other things. We got to actively listen. We got to be non-judgmental. Be careful of your nonverbal responses. Be careful of your physical responses. Definitely maintain confidentiality and privacy. And just make sure you can ask these specific questions, and you're gonna have a chance to do those next semester. All right. So sexual harassment, I'm not going to, over in the workplace, sexual harassment in the workplace, I'm not going to really cover this. Your textbook does, but just know that this is not tolerated in the workplace. And then all the hospitals, or the hospitals here, a lot of companies have sexual harassment orientation, education, and policies. This is not tolerated anymore these days, and it will be addressed. So just know that that's a deal, okay? Now, when it comes to patients that are behaving badly, we don't need to tolerate that. Back in the day, just like waitresses, they come up and take the patient's order, and then when they leave, the male client gives them a tap on the behind. Things like that happen in the hospital as well. We do not need to put up with that, and we can confront our patients about them. We need to do it professionally, but we can confront our patients and say that will not be tolerated. And if it continues, then we do the two people in the room every time. If we have a patient who is totally inappropriate and cannot behave, whether that's verbal, nonverbal, physical, or whatever, it's not tolerated, and there's ways that we can protect ourselves, okay? So here's some nursing diagnoses for your patients with sexual dysfunction. Here's some more nursing diagnoses you can use. Here are your patient goals, okay? So I do want to kind of run through this because I'm running late on time, and I've got another chapter to go over. One thing I want to look at. Okay, so okay, so we've kind of already talked about this. Therapeutic communication, maintain privacy. We've got to educate our patients on sexual health, because they may not know. Literally, they may not know, and this may be news to them, and they probably would really appreciate the education. So teach them about risk prevention, safe sex practices. They may need counseling for patients who do have sexual dysfunction. We need to set them up for counseling. We will definitely need to be, if our patients have risky sexual practices or are coming in for sexually transmitted disease testing, we definitely want to teach them about how to prevent, to make some appropriate choices, maybe not to be having sex with everybody in town, no IV drug use, things like that. We need to teach people, okay, because some don't know. When it comes to patients coming in who are victims of a sexual abuse, there are actually special nurses that we can use. So the sexual assault nurse examiner. So a lot of big cities have a nurse who's trained. Like she's probably she's probably an ER nurse, or maybe she's a med-surg nurse, or maybe she's a OB nurse, but she has had this special training to be a sexual assault nurse. So if we get a patient in the ER who's been sexually assaulted, they'll call this nurse. She comes down and takes care of this patient. Plus, there's a whole team of people, the SART team. You might have a SART team, okay? So that would include, the SANE nurse, support people, counselors, social services, maybe some forensic people, things like that, just depending. So if you do have a patient coming in with evidence of abuse, we need to know our specific rules on reporting. So if we have a patient coming in and it's maybe not necessarily a sexual assault or sexual abuse, but she comes in with domestic abuse, and we need to question her about what's going on, and her partner is with her. Like, it's hard to get her to answer honestly if her abuser is with her. So we need to somehow very sneakily try to get that patient alone. So asking the abuser to leave is not going to work. And as a matter of fact, it will put him on the defensive, or her, I'm sorry, him or her on the defensive. And so that wouldn't be great. So we need to try to figure out ways to get this patient alone. Like maybe, we can be doing our assessment or our history, and we suspect something's going on or something's happened to our patient. We want to ask her these questions. We need to get him out of the room. So we say, oh, I forgot to get her a glass of ice water. Here's the cup. Can you just go down the hall? It's right there on the left, and get her some ice water. And then if he leaves, then ask these questions. If you can't get him to leave, then just continue on with your things. Don't make it a big issue, and then say, okay, well, I need to get you up to the bathroom to get a urine sample. I'm going to take you to the restroom. Take her into the restroom and go in with her and ask her these questions. Do something. If she comes in and for whatever reason she has to have an x-ray, and you can't ask this question when she first presents, go to x-ray with her and ask the question. He cannot go in the x-ray room with her. Okay, so we need to do things like that. Let me look here. If you do, wait a minute. If you do actually talk to her and get specific information from her, you have to write her like almost in quotes. Well, not almost. Like, you cannot paraphrase what she's saying. You have to verbatim write what she says. And this is because if this goes to court or this needs to be used as evidence, we can't have you paraphrasing. The abuser's defense attorney will use that to create doubt and whatever, and say that you're just assuming or whatever. Okay, so we need to have record verbatim what the patient says. Now, okay, so let me just go on here and look. Now, you do need to know what the legal ramifications are if you discover a patient has been abused. You need, if it's an adult patient, you can't report without the patient's consent. If it's a underage person, you most definitely can. If the patient has been abused and they want support, counseling, we need to get that arranged for them, and let them know about their resources. The other thing I just wanted to remember to point out is when you're talking to people about if you are definitely knowing that you're dealing with sexuality issues, or if you're dealing with care plans that may affect sexuality, you need to tell the patient that that you would like to discuss this with them. Is that okay? Are they willing to talk? Are they willing to talk to you about it? Okay, so just come right out and ask them. All right. So last chapter is death and loss. Okay. Here we go. We're going to do this one quickly as well. All right, death and loss. Here are your learning outcomes for the chapter. Okay. So when it comes to to people who have lost a family member, like there are real physical and of course emotional things that go on that they're dealing with. So know that there are. There's a physical realm. There is of course an emotional realm. There can be a cognitive realm to this. So like the forgetfulness and disorganization and being confused and all those kind of things. But a behavioral. So yes, they are going to be crying. They may withdraw. They may have poor work performance. These are all issues that a person is going to be dealing with when they're faced with death and loss. There's some people who all have their own model of grief, stages that people go through in dealing with grief. The one that most of us are probably familiar with is this one: denial, anger, bargaining, depression, and acceptance. So it just, so these different, even all these other people's stages, these different stages do not necessarily happen in the order in which they're listed. And people may bounce back and forth between different stages before they've actually completely have dealt with their grief. Okay, so going through all these stages, and actually there may even be some stages that people don't even go through. Okay, so just know that these are all possible places where a person can be, and no one direction through the stages is always correct. Okay. Oh. All right. Dysfunctional loss and grief. So complicated grief is or unresolved grief is when the person is not able to heal from their grief or go through those stages by 6 months or more. Like by 6 months, I'm sorry, I'm saying that wrong. So they're not able to get through all those stages of grief by 6 months. So longer than 6 months, they're still going through these different stages. Okay, that's complicated grief, and I don't like that definition, but that is the textbook definition. People, I mean, so people can be in grief for longer than 6 months and then not really being complicated. I mean, this is a really personal progression, and some people may take a little bit longer than 6 months, but as long as they're progressing, I don't consider it complicated. Okay. But be aware that if after 6 months someone is still having huge problems, that if we go back to these symptoms that they're having, if they're still having these symptoms, 6 months beyond, then yes, maybe there's some issues that we need to intervene with. But the grief process can probably take longer than 6 months. But there are some complicated or just complicated things. So chronic grief, like those reactions, those symptoms we discussed before, they do not diminish. They continue and continue at that same intensity over a long period of time. Delayed grief is where they do not display the grief. They do not go through those stages in order to avoid the pain and accepting the grief, okay, or dealing with the grief. Exaggerated is, is kind of like the chronic, or not the chronic, exaggerated. So those signs and symptoms are still very overwhelming. The patient can't function, okay. And then masked grief, they do things to actually cover up their grieving process or to cover up the pain, and those can be really dysfunctional things that they do. Disenfranchised grief. This is a big one, okay? This is the one I really want you to kind of know about. It is a grief that is not validated or recognized by society. So these kind of people are people whose family member committed suicide, or maybe their family member died from an overdose, or maybe their family member died from they were driving while intoxicated. Or maybe this was a miscarriage that happened. It's not recognized or validated by society. That's disenfranchised grief. And so we need to be careful about that, especially the way we present ourselves to the patient. And people may make comments like especially with the miscarried child, we may say something, well, there was probably something really wrong with the baby, so this is really great that this happened. Or if it was, let's say it was someone who was in prison and died. So maybe they were a murderer and they were executed. And so the family member is mourning that person, but everybody is like rooting and clapping and hooraying because they were just executed. So there's some things for you to consider. Hold on a minute. Okay, I think there's some other terms that I missed and I don't see them. Maybe we'll come across them. Okay, factors affecting people during the grieving process are definitely like the age of the person who died, or the age of the person who's mourning, the health status of both the survivor and the person who died, like did they have a terminal illness? A person's, if they have any type of religion or spirituality that defines death for them and maybe provides a supportive answer for them, things like that. Do they have a support system? So these all affect a person's grief, okay? So here's some assessment, health assessment questions for you. Talking to the family, like people are afraid to say things, and then sometimes people say stupid things, but letting the person who's grieving know that you're there and you're concerned, and giving them permission to express what they're feeling. Those are great things to say to your patient. Patients anticipatory grief. So this is the family whose this is the people whose family member is dying. They're on hospice care, or they're on life support, and they're going to terminate life support. They know this person's going to die. These are some things that we can talk to the family about, before the death. Okay. Dysfunctional grieving. People are having a hard time dealing with their grief. We need to ask some questions, like especially, do they have a support system? Are they doing this alone? Are they using alcohol or drugs to mask their grief? Are they having problems sleeping? Can we help them with their sleep? Are they eating, or overeating or undereating? Are they gaining or losing weight? Like, we need someone who's having a dysfunctional grieving. We're going to need to intervene and find out what all is going on, and address those issues and help them with them. Now, let me look at something here real quick. Okay, Okay. Hold on. I'm just looking. Okay, so I think I can go on here. Oh, nope, I didn't talk about this one. So there's some signs that we as nurses can see for patients who are about to die. This is impending death, and this doesn't mean it's going to happen in an hour or even in a day. So weakness and fatigue, increased drowsiness, sleeping more, responding less. Like I've seen people in that state for weeks. Okay, decreased oral intake, like I feel like some patients I am force feeding because they won't wake up and they won't eat, and they can be in that state for weeks. Changes in bowel and bladder elimination, of course, constipation, but what I usually see is incontinence. Okay, they can be in that state for weeks, so it doesn't mean that it's going to be happening on your shift. Symptoms of imminent death. So a decreased urine output. Now that one is a tricky one because we can have decreased urine output for this patient back here because they are drowsy, they're sleeping more, they're responding less. We can't get them to wake up. We can't get them to take in a lot of oral fluids, and so they are going to have a decreased urine output. So that one's kind of a tricky one, but cold and mottled extremities, vital sign changes in vital signs, those can be really imminent signs of death. Changes in breathing pattern, absolutely. If you go back and look at some like Cheyne-Stokes breathing, you might see, or the death rattle, what we call it. But even when you see these changes in breathing patterns, someone has a respiratory rate of 4 to 6 or 4 to 8 per minute, you're like, this patient can't maintain this for long. Their SATs are in the 70s, and it's still hours. Okay, so imminent doesn't mean like in the next few minutes, like hurry up and get here, but it does mean like, I don't even know what to say as far as like what it means. But anyways, okay, and so okay, so nursing diagnoses for people dealing with grief are listed here. Here's some that are listed out that you can review. Here are some patient outcomes or family outcomes. So what are the things that we're going to do? Well, patients who are dying, they're going to be on hospice or palliative care. And so hospice is basically comfort, supportive care for people who we know are going to die, that they could be on hospice for several weeks. There are hospice nurses, and so a hospice patient can be hospice patient in home or in a hospice type facility. And then palliative care, you know, this is for your dying patients, but and both of these are for patients and families, but you know, we're really trying to improve palliative care. We're just trying to make the patient as comfortable as possible. You know, pain relief, symptom relief, providing spiritual and psychosocial support, things like that. And so palliative care and hospice care are kind of like dual things, okay? I mean, dual things. They coincide. I'm sorry, they coincide. Things we can do for our patients that are in the hospital or in the hospice house, or do for them at home, is, you know, you can still bathe these patients, but do it gently. You know, do provide peri-care and things like that, clean linens, clean gowns every day or however often, making sure you're keeping them clean from incontinence. and be as gentle as possible. And it doesn't have to be a full-fledged bath, because these, bathing a patient, moving them around and things like that, can be painful and very uncomfortable for them. And we don't want to be causing that for a patient who's dying. Definitely going to be providing oral care for people who are dying. A lot of times these people are mouth breathing and they've got dry, crusty mouths. We can just make sure we keep their mouths hydrated with moist stuff, but being careful, like with aspiration precautions. Turning these patients, repositioning them, cushioning them up, giving them pillows and all these kind of things, trying to keep them as comfortable as possible. But remember, like, even turning can be painful to people. And then, but we still want to do it. We don't want to, have these patients be developing skin breakdown and decubituses while they're dying and having those issues to deal with as well. People may be, a dying patient may be agitated and restless. So we just try to keep them as peaceful and as calm as possible. Try to figure out what works for this patient. We may be giving pain medicines, anxiety medicines, and we may be giving bigger doses than you've ever seen in a patient who's not dying. We may be providing oxygen for these patients, of course. And then, these patients may not be swallowing foods or medications, or they may be having problems with nausea and vomiting. So we may need to find another route to give them their medications. So we've already talked about relaxation type things. Yes. So patients may not be able to handle the secretions. So we might want to keep suctioning available, like a Yonkar suction, to keep their airway, try to keep their airway clear. That would be horrendous, to allow a person to like drown in their own secretions or choke on their own secretions during their last hours and stuff. Patients may have periods of when they've been pretty much out of it and not arousable and not communicating or anything. May have sudden periods of being aroused and being fairly coherent. Or they may have periods where they seem to be communicating with someone, but they're not communicating with you or the family. Like they seem to be communicating to someone else. Like, we can acknowledge this kind of stuff. We can try to interact with the patient. We can ask them, who do you see? Who are you speaking with? Things like that. And then just allowing the family to, to be with the person who's dying, to, they tell stories about the person, and, they laugh and they cry and they do whatever, and just allowing them to do whatever, saying their goodbyes, talking to the patient, even though the patient is not responding. Please allow all that. And of course, if this is in a hospital and stuff, just to make sure that you can provide them with as much privacy as possible. It's really hard for nurses who work in hospice care. It can be really straining on a nurse emotionally. So kudos to those nurses who are able to do that. But also, we just need to, when this patient does die, we just need to make sure that the family can be with the patient as long as they want to. And then when they're ready to hear this, making sure we give them, information about resources for grief and bereavement counseling and things like that. The nurses who take care of people who are dying, they need to have an outlet as well, so that they can continue to provide care for this special population of people. All right, and then let me just wrap up here. All right, I think that's all I have to say. So, so no class, of course, because you're listening to recording, and then I won't be in lab this week, and then next week, remember you have your this week on Friday you have your thing at St. Pat's in room 3 of the Broadway building. Meet Ann there about 10 minutes before 11. And then you'll go to the deal. And then the following week, there's no class on Wednesday or Thursday or Friday because that's Thanksgiving. So I won't see you again until I think it's the 28th of November. So have a great Thanksgiving.